Hello everyone, my name is Mario Mandala. I am Professor of Medical Oncology at the University of Perugia. Thank you organizers for inviting me. Thank you Gabriella, and maybe next time I can meet all of you in person. The title of my presentation today is the perioperative treatment in melanoma, and this is my agenda for the next 20 minutes. I will cover the unmet medical need in stage 3 disease, the biological background of neoadjuvant therapy, the evidence derived from phase 2, meta-analysis, phase 2 randomized and phase 3 randomized clinical studies, and what we need in perspective. So we use adjuvant therapy in stage 3, and the way we use the treatment in stage 3 is based on the results of 3 randomized clinical studies. The 054 study comparing pembro versus placebo, the 238 comparing anti-PD-1 nivolumab versus ipilimumab, and the third study, the COMBIAD study in BRAVO 600 mutated patients comparing dabrafenib trametinib versus placebo. Overall, we know that the benefit of patients is in absolute terms of 15 to 20% with 1 year of treatment, and the number needed to be treated to spare one patient a recurrence is close to 4 to 5. So what is the need for the neoadjuvant therapy? And the need is here explained in this slide. For all the clinical studies with immunotherapy, you can see that in the first 3 months, we have a step of 20% with IPI, with pembro, and with nivolumab. So in the first 3 months, we have 20% of patients who ultimately recur. And in addition, in the screening phase, particularly for patients with palpable nodes, we have another 15% of patients who recur before starting adjuvant therapy. So overall, we have a 35-40% recurrence in the perioperative phase. So we need a neoadjuvant approach or another approach in order to cover this unmet medical need. What is the biological background of neoadjuvant immunotherapy? And the biological background has been explained and shown and demonstrated in this elegant preclinical study published some years ago in Cancer Discovery. So mice were randomized to receive a neoadjuvant approach versus adjuvant approach. And the neoadjuvant approach was based on Treg depletion, anti-PD-1, anti-CTLA-4, the combination of anti-PD-1 plus anti-CTLA-4 or anti-TIM3, or the combination of anti-PD-1 and CD40, or the combination of PD-1 plus IL-2. And as you can see here in the Kaplan-Meier curve, there was an improvement in terms of overall survival in mice treated with neoadjuvant immunotherapy compared to adjuvant immunotherapy. So what is the proposed mechanisms of action of neoadjuvant immunotherapy in presence of the tumor in the neoadjuvant approach? So the conditio sine qua non is that we have T cells, and there is an interferon gamma signature and the release of interferon gamma by T cells. So we need an immune system that works. What happens is that in presence of the tumor, we have the release of cancer cell antigens. These cancer cell antigens are presented to antigen-presented cells, for example, dendritic cells. There is the priming and activation of T cells. they traffic into the blood and in peripheral tissues. They can infiltrate the tumor. They can recognize the tumor. They can kill the tumor. And again, there is a release of cancer antigens. So there are new T cells that are stimulated, expanded in quantity and quality, new T cells that can kill the tumor. But in addition to this mechanism, there is also the re-expansion and recirculation of existing tumor-specific T cell clones. But what is important to drive the long-term response is that we can stimulate functional circulating CD8 positive T cells that can in turn they have a role in metastasis control and memory differentiation T cells that are important to maintain the long-term response. If we look at the stage distribution in melanoma, we know that the majority of patients are with stage 1, 22% of the patient with stage 2, 8% with stage 3, and 5% with stage 4. Among patients with stage 3, we have 30-40% of these 8%, that means the 3% with palpable nodes. But in addition, in the era of sentinel lymph node only procedure and for stage 2, with a sentinel lymph node negative, we can see also the local recurrence with a palpable node. So overall, patients with palpable nodes that can derive a benefit from neoadjuvant approach are more or less 18 to 20% of the patients. And we know from the meta-analysis of neoadjuvant studies that first, immunotherapy works better than targeted therapy. And the reason of this is why patients with pathologic complete response, near pathologic complete response, so with viable tumor cells less than 10%, and patients with a partial response have a very nice long-term control of the tumor. And this works much better with immunotherapy compared to targeted therapy. And then we have data from a phase 2 randomized clinical study, the SWOG S1801. In this study, patients with palpable nodes were randomized to receive 3 cycles of pembrolizumab before surgery, then surgery, and 15 cycles of pembrolizumab in the post-operative setting, compared to surgery and 18 cycles of pembro. So overall, the same cycles of pembro in adjuvant or neoadjuvant approach. And there was a 23% of absolute benefit in terms of relapse-free survival at 24 months. So an improvement of the outcome in terms of relapse-free survival with the neoadjuvant approach. And the majority of patients who ultimately can benefit from this approach are those with interferon gamma high and TMB high, or those with interferon gamma high regardless the TMB, and those with TMB high. While there is a subgroup of patients with interferon gamma low and TMB low that derive a benefit, but the benefit is less than the other subgroups. But from a surgical point of view, what is the advantage of the neoadjuvant approach? So can we omit the total lymphoadenectomy? And there is a first small study, the MEMALOC study, that is a sub-study of the OPACIN Neo, a phase 2 study using EP1 and NIVO3. A seed was included in an index palpable lymph node, patients were received 2 courses of Ipi/Nivo and then the total lymphadenectomy. And there is a very nice concordance between the pathologic response in the index lymph node compared to the other lymph node in the basin area. And these results were confirmed in a larger study showing that there is a very nice overlapping in more than 90% of the cases. So we can remove the index lymph node, and the result in the index lymph node mirrors what happens in the other lymph node. So this is the background of a future clinical studies comparing the total lymphadenectomy and only index lymph node after preoperative treatment. But the notion and the idea and the hypothesis that we can omit the total lymphadenectomy without compromising the outcome of patients has been demonstrated in the Prado study. In this study, those patients with pathologic complete response or pathologic near complete response with less than 10% of vital tumor cells did not receive a complete lymphadenectomy. And here you can see the very nice overall survival in terms of relapse-free survival and distant metastasis-free survival. So we need a randomized clinical study, but the data that we have are very, very promising. And this year, in the plenary session and with a concomitant publication in the New England Journal of Medicine, the NADINA trial, patients with palpable nodes were randomized to receive preoperative neoadjuvant therapy with Ipi/Nivo, then total lymphadenectomy. Those with major pathological response, near complete response or complete response, no additional treatment, and only follow-up. And those without major pathological response, they started the standard adjuvant therapy with immunotherapy or targeted therapy. And the comparator was the standard total lymphadenectomy and then adjuvant study. And the primary endpoint of the study was the event-free survival. Overall, 212 patients were assigned to neoadjuvant group, and 211 were assigned to the adjuvant group. The patient characteristics are here shown, most of them with palpable nodes and minority with intransigent metastasis, most of them with a palpable node with an enlarged lymph node of 3 centimeters or less, and 50% with BRAF mutated melanoma, most of them with normal LDH. And the primary endpoint is here shown. There is a 68 relative risk reduction of relapse-free with a benefit, the absolute benefit of 26% in the neoadjuvant group compared to the adjuvant group. And all subgroup of patients based on sex, age, ECOG, T-stage, ulceration, intransigent metastasis, BMI, location of affected lymph node, sum of diameter of lymph node, BRAF mutation, LDH, and previous treatment benefited from the neoadjuvant approach. And as you can see here, the benefit was regardless of the BRAF mutation. And again, there was a very nice long-term benefit without recurrence in patients achieving a complete response or a near complete response with less than 10% of vital tumor cells. Based on these studies, a group of researchers and scientific organization made a call to the regulatory authorities to introduce neoadjuvant therapy for our patients, at least the monotherapy, and trying to introducing after the presentation of the combo immunotherapy, even the combo immunotherapy as a neoadjuvant approach. The neoadjuvant approach is not yet approved in Europe, is approved in US, and is approved in Australia. So what are the opportunities for the neoadjuvant approach? We have preclinical and clinical data supporting neoadjuvant, and we know that neoadjuvant is superior over adjuvant in patients with palpable nodes. We can de-escalate the strategy because in patients without a pathological response, a complete pathological response or a major pathological response, they still need adjuvant therapy, but we can spare adjuvant therapy in those with a pathologic complete response and near pathologic complete response. We can, in perspective, limit the extent of surgery, and we can tailor the way we treat patients in the adjuvant phase based on the response of the neoadjuvant approach. Of course, there are some limits. We can approach only patients with palpable nodes with the neoadjuvant strategy. In the Nadina trial, there is still a short follow-up, so we need a longer follow-up. We need, of course, and this is one of the limits, a learning curve for pathologists, because we need to wait, particularly in the community hospitals, that pathologists can learn, can improve their knowledge and the way they see the lymph nodes after the neoadjuvant approach. And we have some open questions, including which regimen, monotherapy versus combo immunotherapy, how long, 2 cycles, 3 cycles, 4 cycles, for which patients, for all patients, yes or not, and the role of adjuvant therapy after the neoadjuvant approach. So I want also to remind you that at the end of September, we have the Italian Melanoma Intergroup National Congress, a must to attend. And I would like to thank also the independent grants that support my research. And I want to thank you again for the kind invitation, and hope to meet you in person next year. Thank you very much again.